I'm Kieran Anderson, the group publisher here at Applied Radiology, and today we're here to talk about the evolving role of contrast-enhanced ultrasound in the diagnosis and management of hepatocellular carcinoma, otherwise known as HCC. Our goal is to really better understand where contrast-enhanced ultrasound adds the most clinical value, whether that's in characterization, treatment planning, or follow-up, and how it really fits into the broader imaging pathways alongside other modalities like CT and MR. To start us off, I'd like you to kind of just take a step back and walk us through what exactly hepatocellular carcinoma is, why is early and accurate diagnosis really so important for really directing appropriate patient care?
HCC, hepatocellular carcinoma, is the most common primary liver cancer in the world. And by primary, I mean that it grows from the liver cells as opposed to malignancy that may travel to the liver, like colon cancer, like metastatic disease. HCC is the third most common deadly cancer in the world, and it's increasing in incidence. So unlike breast cancer or prostate cancer, where we're making strides in reducing mortality, the incidence and mortality in HCC are actually going up. HCC is often associated with chronic liver disease, and that could be from hepatitis, viral hepatitis, alcoholism, but more commonly now, metabolic-associated steatohepatitis, often associated with obesity, diabetes, which as we know are worldwide issues. And so that's contributing to the increased incidence in chronic liver disease as well as HCC, and therefore it is paramount that we have a strategy for identifying those patients, because there is really good literature to show that early detection can save lives, and late detection has horrendous outcomes. We're talking about very, very poor 5-year survival rates. So when we're talking about identifying those patients early, you're talking about screening, surveillance, and accurate diagnosis.
Dr. Gupta, how would you explain what hepatocellular carcinoma is, and why we look for this?
So I think HCC is obviously a big public health problem, and it's got risk factors that include alcoholic liver disease, viral hepatitis, and now kind of metabolic associated liver disease. And the biggest thing to understand about HCC is it's a disease that has an incidence of somewhere in the range of 1 to 6% per year in cirrhotic patients. And so as radiologists, one of the key things that we have to do is take a look at these at-risk patients and monitor them in a screening way to assess their likelihood of developing a lesion that is consistent with hepatocellular carcinoma. Identify it early enough, but be really, really sure about the answer. The reason being that one of the options in HCC is transplantation. And before you transplant a liver, you absolutely need to make sure that the lesion that you're transplanting is hepatocellular carcinoma. So the tools that we have in our armamentarium to do this thing right now are ultrasound, CT, and MRI. And each of them has kind of unique things that we can talk about, but that's kind of a backdrop of the environment that we're working in.
Dr. Mazzarelli, based on what Dr. Gupta just said, as you think about it, from a clinical perspective, what kind of observations would you have about, how this plays out, how the chances of a delayed or uncertain diagnosis and the impact of that might play on a treatment pathway for a patient in a real world sort of situation?
Well, liver imaging is challenging. Liver imaging is challenging with every modality, whether it be CT, MRI, or to some extent contrast ultrasound. First and foremost, to Dr. Gupta's point, we're seeing more and more hepatocellular carcinoma. The rates of HCC are increasing, and we're using screening with ultrasound as our modality by which we look for that cancer. We use CT and MRI to corroborate the findings that we find on ultrasound. And there are challenges. When we have these patients, a lot of them are not the healthiest patients. So when we ask them to do a CT or an MRI, sometimes the challenge is breath holding. We're allowed to give a dose of contrast once, and the timing has to be so critical. And so that critical timing, especially for HCC, it's a type of tumor that we see because of arterial enhancement. When there's early arterial enhancement, that's the critical feature, and then washout. And those features are something that we need to look at across all modalities. So the point here is that we need great modalities that talk to each other. CT, MRI, and contrast ultrasound that can occupy their own spaces and help in this journey, because getting it wrong is not an option. And we can get it wrong because there's a lot of false positivity. And that false positivity can be alleviated by utilizing these great tools that we have in our armamentarium. So it's going to be a bigger problem 5 years from now. The rates keep increasing, so we need to have great technologies.
You both mentioned sort of the role of multiple modalities here, CT, MRI, ultrasound, and today really CT and MRI, if you think about it broadly, probably remain the most common tools used for diagnosing and characterizing HCC. Where does contrast and ultrasound sort of fit into this diagnostic workflow in your opinion today, Dr. Gupta?
We use it in our practice for routine liver biopsies where we're trying to assess whether a lesion, which could be quite subtle which is evident on CT or MR, but not as evident on ultrasound, to make that lesion more conspicuous, allows us to more accurately biopsy it, have a cytopathologist in the room who helps us know that we're in the lesion. I mean, this helps reduce the rate of inadequate biopsies as well, not just in the setting of HCC, but across a whole host of liver lesions. Right. So LIRAD specifically addresses the role of CT and MRI, and now it specifically addresses the use of contrast-enhanced ultrasound. So I think what that shows is that contrast-enhanced ultrasound definitely has a place in the diagnosis and characterization of focal liver lesions. I think the key thing to remember about where does CEUS potentially have some real value, arterial enhancement is a critical feature. And sometimes a lesion demonstrates arterial enhancement, but doesn't demonstrate the washout of the capsule that helps us take it from a LIRADS 3 lesion to a LIRADS 4 or a LIRADS 5. So one of the ways in which we can use contrast-enhanced ultrasound is to say for lesions that are arterially hyperenhanced, but we don't have some of the minor criteria or major criteria that allow us to make a diagnosis, is use CEUS to help us troubleshoot those lesions and help categorize them into arterial hyperenhancement that is worrisome or arterial hyperenhancement that is more perfusional and non-worrisome. That's a place where I see CEUS having a real problem-solving role in the setting of HCC.
We also use contrast-enhanced ultrasound when CT or MRI can't make the final diagnosis. Either CT was only a single phase and you normally need multi-phase post-contrast imaging to make that diagnosis, or maybe there was an artifact in the MRI that degraded some of the images. And so in those cases we use contrast-enhanced ultrasound as a troubleshooting tool to help either improve our confidence in the diagnosis or even make the call when CT or MRI couldn't.
And I would add also, patients have limitations, right? Some patients can't have MRI, they can't have CT, they have kidney dysfunction, or they have MRI-incompatible devices. So then you have CEUS as an alternative modality that's incredibly safe, well-tolerated, and it has the advantages of incredible spatial and temporal resolution. So to Dr. Gupta's point, one of the things that we see sometimes on MRI are transient arterial hepatic lesions, things that are actually just perfusional but not structural. And we can use CEUS to troubleshoot those things. The other side of this also is that not everything that we encounter is HCC. There are benign lesions like hemangiomas and focal nodular hyperplasia, and there are malignant lesions like cholangiocarcinoma. And one of the real benefits of CEUS is to be able to distinguish between HCC, CEUS, and cholangiocarcinoma, hemangioma, FNH, and benign lesions like cysts. So all these tools working and complementary with each other, very powerful.
Yeah, I think it's a really critical point, and I think one thing to your point about some people not being able to do MR or CT, one of the other things we're hearing about all over the world right now is the huge utilization of cross-sectional imaging. So one of the places that I could see CEUS is actually helping us in scenarios where there's a long wait time to get a CT or an MRI, right? Many times you've got a screening ultrasound. That screening ultrasound is telling you there's some lesion that needs to be further evaluated. You may have a 3-week wait, 6-week wait for a CT or MR. Imagine the situation where you could take that patient in just days, put them into a contrast-enhanced ultrasound pathway, and get them on their diagnostic journey quicker, or get them on their therapeutic journey quicker. So I think that's a real place that it could really live. I think also patient selection is an important part there too. If somebody is not in great health, has an inability to hold their breath for extended periods of time, does have renal dysfunction, does have allergies to contrast, all of a sudden you bring in a modality that is much lower touch in one sense and much higher touch and personalized in another sense. So I like it in that format.
What types of liver lesions or clinical scenarios really truly benefit the most from CEUS?
I mean, there's so many indeterminate liver lesions that we come across of all different milieus. Obviously, when you have an abnormal liver, cirrhotic liver, our antenna are up for HCC. But that doesn't mean that you can't have other malignancies within that liver or benign entities. So it's very critical in the HCC spectrum to be able to distinguish definitively benign from malignant. And when you can actually say that something is an FNH, focal nodular hyperplasia, because it doesn't demonstrate that late mild washout, versus an HCC that demonstrates that late mild washout, that's practice changing, that's life changing for the patient. Or on the other side, when you can say that something washes out very rapidly in that first 60 seconds, that's not an HCC, that doesn't behave like an HCC, that's a metastatic lesion or a primary neoplasm outside of HCC. This really helps us to actually put the patients along the right path in the treatment paradigm. And also you have to remember, to Dr. Gupta's point, we're using ultrasound to screen. So not always the things that we see on ultrasound can be seen on CT or MRI. And similarly, sometimes the things that we see on MRI cannot be seen on ultrasound. So again, we need these two tools to be investigators, to try to find the things that we need to find.
In your opinion, how does contrast-enhanced ultrasound really support that overall imaging journey from initial lesion detection to helping you guide those downstream decisions, such as referring to, say, an interventional radiologist, for example? What are your thoughts there?
I definitely see contrast-enhanced ultrasound having an impact across the care continuum, as you mentioned, both in initial diagnosis, in assessment of treatment response, regardless of what that treatment may be, and we can go into details if you wish, and then in interventional radiology, using contrast-enhanced ultrasound to help target a mass and confirm needle placement, or to help guide some of those therapies. Contrast-enhanced ultrasound in the interventional suite is actually where I got started with CEUS, because I do liver biopsies and other interventions, and I found that the improvement in being able to visualize the lesion during the biopsy or treatment and improves my diagnostic yield, and that has been shown in multiple publications. You know, when you have large masses, sometimes they become necrotic, so the contrast-enhanced ultrasound can help you find the viable tumor versus the dead tumor, and it helps you improve your diagnostic yield. It may help you visualize the lesion for more precise needle placement. And then if you're also doing any kind of ablation procedure, like microwave ablation or radiofrequency ablation, it can help you not only target the lesion, but immediately confirm successful therapy, because you can do contrast-enhanced ultrasound immediately before and then immediately after your ablation, and to show that the entire lesion was adequately treated.
One thing that I'd love to talk about in the interventional space is the ability of the modalities to make things visible or invisible. So we don't uncommonly encounter scenarios where something is invisible before we give contrast and then visible after contrast. And so, you know, especially if we're on the fence about what something is and we can't quite tell, the ability to see it, especially with contrast, and then biopsy it under contrast guidance if needed, if it doesn't meet the criteria for an HCC, doesn't have that late mild washout, doesn't have that capsule, can be very powerful. So that from a diagnostic perspective and interventional perspective can be very, very helpful as well. And we use it commonly now to help troubleshoot complex cases, and it's really been a lifesaver. So we can not only see it and diagnose it, and we treat it, but we can also assess response, okay? And that can be beginning from day one. The ability to look at a lesion that you treat and determine whether or not you fully treated the lesion that day with contrast as a complementary feature to CT and MRI. And then similarly, to actually look at the path of that lesion over time. Watch the response criteria. Is this a benign response? Is this residual malignant disease? And that can be very challenging on MRI or CT. Sometimes we have blood product. Sometimes we have protein deposition, and these things can actually really kind of muddy the waters. The thing about contrast ultrasound, it's a true intravascular agent, and it oftentimes is the truest contrast imaging agent, because what we see is real enhancement. It's not pseudo-enhancement, it's not interstitial leak, it's enhancement happening at the site of treatment, and that's very powerful to know when we need to retreat, if we need to retreat, and so we're using it in that whole paradigm of treatment, diagnosis to treatment, and then retreatment as needed.
What aspects of LIRADS for CEUS are most important to understand, and really, how does that help improve confidence and consistency for those that may not be aware?
So the American College of Radiology has several RADS systems. So we probably have all heard of BI-RADS for breast, there's TI-RADS for thyroid, and LI-RADS for liver imaging, specifically for the definitive diagnosis of HCC. LI-RADS has been around for a long time, focusing mostly on the diagnosis of HCC using CT and MRI. But LI-RADS is diversified to focus on various aspects of liver imaging, as well as incorporating contrast-enhanced ultrasound. So now there are multiple algorithms that include contrast-enhanced ultrasound, including one for the definitive diagnosis of HCC. I was fortunate enough to be in a seminal multi-center trial that looked at the diagnostic performance of CEUS for HCC, and we found that the positive predictive value, the specificity, was just as high as CT and MRI. So when you call it an HCC or a LI-RADS 5 lesion, at CEUS, you have that same diagnostic confidence as you would if that patient underwent a CT or MRI. In at least the United States, that's very important because assigning a LI-RADS 5 category has major management implications. It means that they can qualify for exception points in liver transplantation, and it means that you can confidently treat that as an HCC and proceed with downstream treatment decisions without a biopsy, which is huge. And recently, the United States Organ Sharing Network, who makes decisions on who would qualify for a transplantation, has accepted the LI-RADS system as their diagnostic system for HCC, and that does include CEUS. So for the liver transplant centers here in the United States now, any of the diagnostic modalities, CT, MRI, or CEUS, can now be used for diagnosing HCC and helping qualify that patient for transplantation, which is huge.
In your opinion, as a practicing radiologist, how broadly known is this? How many people are doing it? Because it seems to me that while it's been around a long time, it's not widely used.
And that's one of the confusing things about the United States is the kind of sluggish adoption of contrast-enhanced ultrasound, despite all of the benefits we've just been talking about. Right. So I think one thing that helps is something that LI-RADS is doing, is it's incorporating CEUS into the diagnostic algorithms so that it's held at the same prominence as CT and MRI. But a big part's also going to be education. You alluded to the fact that many people may not know about contrast-enhanced ultrasound. And so, each site that wants to do CEUS, there are many resources out there, online, through various manufacturers of either ultrasound units or of contrast agents who can provide on-site support for anyone who wants to get started. And then leaning into some of the online educational resources or public publications. And there's a community of us in ultrasound here in the United States and worldwide more than happy to help sites get started and to help educate either those in radiology or referring clinicians that may be interested in sending patients over for a CEUS. So it does require a groundswell and a critical mass of people who are interested and confident and competent in CEUS. And I'm hoping we're at a precipice where we can push through some of those barriers, expand education, and expand utilization here in the United States.
I'd like to start thinking about how do institutions integrate contrast-enhanced ultrasound into their practice more fully, right? And there's probably a number of things that they have to consider as they think about that. There's workflow, there's training, there's staffing, there's equipment, ensuring they have the appropriate use alongside both the CT and the MRI that we've just discussed. From your perspective, Dr. Gupta, in your role, tell us how that works, and how you think about that.
I think the first thing with contrast-enhanced ultrasound is getting educated on exactly what it is. So many people have great awareness of CT, great awareness of MR. With contrast-enhanced ultrasound, there's a few things you need. Number one, the patient who did not need an IV for their regular ultrasound does need an IV for their contrast-enhanced ultrasound. Very similar to your CT, very similar to your MR. So the idea of how do we get these patients IVs? The second thing is you need people trained in this technology. You need your sonographers trained in this technology. You need your radiologists trained in this technology. All of this is possible. And one of the things that I love about being a radiologist is many of us today are experts in something that may not have existed when we were in training. So our ability to learn how to do new things is definitely present. And the willingness to do new things. So I like the idea first of taking education and prioritizing that. The second thing is understanding what does it mean for your practice, workflow-wise. How do you take a patient who has a screening ultrasound that was abnormal? How do you work them in most appropriately for their next diagnostic test? Working with hospital administration of figuring out scheduling templates, understanding how you can work something like this in. Starting small, working bigger, right? Have a certain number of slots per day with a certain set of sonographers to do this, and then potentially work yourself up to more and more days, more and more slots. Really doing that. So I think it fundamentally comes down to education and an appreciation of workflow and not being afraid to try new things.
Great point. Dr. Mazzarelli, you've been doing this in your practice for a little while. What would you add to that?
I would say that CEUS is helping to democratize imaging. There are patients who couldn't get other tests and now have an option. And we never want to restrict our patients from not having an alternative to make a life-changing diagnosis. And the idea of not being able to perform a test because of some issue, whether that be being able to get the test, to Dr. Gupta's point, or because of contrast allergies, now we have an alternative that allows us to democratize imaging. You can get the study because we have an alternative for you. This is nephro-friendly. Don't worry about your kidney dysfunction. Our agents are kidney friendly. We don't have to worry about your kidney function. Maybe you can't hold your breath. This technology is very gentle. If it doesn't work the first time, I can give a second injection and we can retime it again. So I like to think about it as the democratization. It's also something that in our practice, patients really enjoy. I know it's weird to say a patient enjoys a test, but there's a difference between an MRI, a CT, and an ultrasound. An ultrasound is a people-friendly test. Sonographer, I tend to be in the room in a lot of cases, so we try to make the patient feel very comfortable. And people have a sensitivity to MR because of the machine to some extent, but whereas ultrasound, we've all had one at some point in our lives. So it's a very patient-friendly exam, and so that's part of that democratization of imaging.
Looking ahead and looking at sort of the evidence and adoption and the future direction, what kind of recent evidence stands out to you, and sort of looking ahead, where do you see CEUS going in the next few years, and in terms of its role in HCC diagnosis, overall patient management, or even outside of that?
Something we've been talking about is highlighting the holistic approach that CEUS can provide to the continuum of care, right? From diagnosis to troubleshooting to interventional guidance, and then for assessment of treatment response, which we really haven't talked about, but we now have the ability to, after targeted treatment of an HCC, use CEUS for the follow-up to confirm adequate treatment or to detect early recurrence or residual disease. And there's been good literature to show that CEUS is more sensitive and can detect recurrence or residual disease sooner than with CT or MRI. And so the sooner that we can confirm those diagnoses and retreat, hopefully we will see better outcomes. So I think now that CEUS is becoming more integrated into these national and international guidelines, we're hoping that it gets more prominence at both in radiology conferences and literature, as well as non-radiology conferences and literature. And we have, again, a groundswell of support and highlighting and utilizing CEUS in the continuum of HCC care.
I think contrast-enhanced ultrasound has clearly made inroads in Europe, other parts of the world. I think the biggest thing in the United States is understanding how it can be used in your practice and understanding the problems it can solve. Fundamentally, contrast-enhanced ultrasound is a problem-solving technique, and we all like solutions to hard problems. And so if you look at it from that perspective and start thinking, okay, for our focal liver lesion population, for our interventional population, for our lesion detection population across other organ systems, where can we best use this thing? I think that the sky is really the limit in terms of the creativity of applications here. Again, it is a problem-solving technique. So using it as a problem-solving technique is going to be the best way I think we can really expand it over the course of the next 3 to 5 years.
Dr. Mazzarelli, final thoughts.
Well, it's the creativity and it's the future. The future actually is doing what we're doing now, expanding it more universally in the United States. But then it's the technologies that are complementing contrast ultrasound, the post-processing technologies that are allowing us to now unlock the microvasculature. With the spatial and temporal resolution that contrast ultrasound allows us, we can look at microvasculature in a way we've never done before. So I call it functional vascular biology. Contrast-enhanced ultrasound allows us to look at tumors from a vascular perspective in a way we've never seen before. And anytime you do that in radiology, that's pretty exciting.
You know, the creativity and the enthusiasm that you see from Dr. Mazzarelli is actually what is required to build a CEUS practice. The idea of saying, look, we're going to think about it a different way, We're going to take care of our patients. We're going to put them in the center of what we do. We're going to use it in conjunction with the other modalities that we have. That enthusiasm is contagious, and you need a champion inside your practice to really take it to the next level if you're going to take it seriously over the next 3 to 5 years.